So what's an academic health centre? Academic health centres are a global phenomenon. They're essentially the integration of the health system with relevant universities, and it's a global feature of the OECD countries. Australia in some ways has been a bit slow, although you could argue that 30 or 40 years ago we had the elements of them, and some will remember the various professorial units and all those sort of things that had their flaws, and university associations. When that disappeared in the 80s and 90s, new formations of the integration of health systems with universities in particular got underway. In some ways you could argue that the American universities, where they own their own hospitals, has developed these sort of things, particularly since the Second World War. And you do see them in all OECD countries now. They're associated with enhanced quality of care, an enhanced culture of reflection and improvement, increased translation of discoveries and benefits to patients, and definitely enhanced collaboration amongst partners, and region-wide approaches to research, education, patient care and business development. So there's a lot of these, and these are just some, and people in the audience have probably visited some of these. I've visited some of them, and some have been around a long time. There's the big names in the US, which kick this off really. Since then, we've seen the same things develop in Canada, Britain, Netherlands, and Australia. There's been national reports looking at how you'd fund health system research and higher education inside the university sector by a group called the Independent Hospital Pricing Authority that has a teaching, training and research committee that I'm on. And what that means is that when the national efficient price emerges, which is how you get paid in a hospital system, and maybe more than that, it's like how much does a broken arm or heart cardiac surgery get in this place compared to that place compared to other places. The budget that at least is delivered to states, and increasingly that would be what's delivered to districts, will have a line in them that says education and a line in them that says research. And if you don't do it, you won't get the line. So what will be happening rapidly in 2017, 2018, as this rolls out, is the establishment of tiers of health systems across the country. You can see it as part of the global sort of arms race around innovation that's occurring. Our opportunity is to bring our pretty unique backyard together into a thing that we've called the Tropical Australian Academic Health System that we've been working on for some time. So there's been about 2.5 years of development. All the northern HHSs, that's Mackay North, are involved. That's the statutory authorities, you know, Mackay, Cairns, Townsville, and Cape and Torres Northwest, and the North Queensland PHN. In that's probably 750, 800,000 people established over a fair bit of turf. And it's unique because nearly every other centre is in a big metro where you've got a consolidated patient. Imperial College, for instance, is one of the ones we've talked to a lot. They've got 5 million people in their backyard. And so there are numbers of issues about how they consolidate pathways and types of practice and how they integrate that with the British model of funding primary care and how that integrates with the health system. What's amazing now that I've talked to 20 or 25 of these sort of entities in some detail is actually the issues are the same. The heading on the issue is the same everywhere around the world. The context is different, and so the solutions might be different. And when you've seen one, you've seen one. Everyone has come with a different model. So this is a happy snaps, or this is a happy photograph looking at the people who did some travelling around the place. It's broadly seen, I think what's important from the general research community in Australia is unlike many of the things, this isn't being poo-pooed in Melbourne or Sydney, certainly not in Canberra. When you actually talk to the people at Walter and Eliza or the various other places, Centenary or whatever, they're basically saying, actually Australia needs one of these. And it needs to have enough firepower because it's an important region. You've got, the Asia-Pacific developments, and we need an interface there. And actually, that's pretty unusual. Normally, when we're chasing money, we're competing with everyone else, and others don't think our stuff ought to get up. That's not what's happened, but, and I guess it's getting easier and easier to get dough up here. For those who've been around more than 25 years, you can remember what the health system was like then. So it's come an incredible way. I think the academic health centre notion is probably a tipping point, and should it go forward, and I'm really sure it will start to set a global agenda around the sort of work we all do here. I think that's going to be pretty important. Another happy snap. So on 19th of April 2016, these are the representatives of the chairs of the health and hospital services, the PHNs and the various players, including us. And they're happy. And actually that was, if you read into the smiles, these aren't fake smiles. There was like 6 months of hard negotiation about budgets. And so it's got serious, like, what are you putting in? What's in kind? What's in cash? We're reviewing it at the end of 6 to 12 months. And the relief and the thing you're seeing in people's smiles there is actually true. Because budget negotiations are tough, and it's across 7 different entities. So I think that's important. So I think the opportunities for the PHN and the risk is primary health care and primary medical care is actually really, really important in this part of the world. There's incredible health disparities, incredible difficulties in access to services. There's major issues around the recruitment of staff, and that is directly tied into how people who want to take jobs here see their future. So how does that look on my CV? Once you get past the top 30% who are the true believers, who'll be in North Queensland, far North Queensland or Northern Australia, no matter what, you've got a whole middle group of people who want to know, is this interesting? Can I build a research career? Is the other hospitals going to be any good? Is the primary health networks going to be any good? What does it do for me? You'll always have a bottom 30% who'll say, go get nicked. I'm going to squirt in Botox at lunchtime. Oh, look at Pitt Street. What's scary about Pitt Street is when you have a meeting there, you'll see that there's practices open for 3 hours, and that's all they do. And office workers go in, get Botox squirted in, and some pimples picked or something. I don't know what else you do, but stuff like that. And that's part of healthcare too, I guess, but not the bit I'm interested in. So there's, we're going to have to do that. We still do that, and that will develop here as the economy develops too. But there are other really, really big issues here. Research commissioning, I think, will be really, really important, because as the PHN is driving its thinking around its strategic directions and imperatives, it's actually going to have to work out which bits of evidence it's going to use, how good it is, how generalisable it is. Because, oh God, it's my sister trying to ring right in the middle. So, that's the one thing I didn't predict. When you're driving strategy and thinking about the sort of big bit of turf you guys have with the just variety of people and services and stuff, there's some hard thinking to do. And you're going to need evidence for it, where that's credible and possible. Ultimately, it comes down to judgment and dollars too, but evidence is handy. And she's left voicemail, which is really good. So, I'm just trying to see how my time's going. Oh, okay. So, I think we've sort of said that. there's been quite a bit of activity. There's several ways this could play out. My guess is in about 2 years, there'll be a federated body that's an academic health centre. Possibly in about 6 months, there'll be a confederated structure as people get used to each other and how the arrangements are made. You can see that across the country too. There's Sydney Health Partners, which is pretty loose, and it's around Sydney University. There's Monash Health Partners, but there's the Melbourne University groups, and some of that's quite consolidated. At the moment, it's sort of an association. My guess is we'll rapidly move to a confederated model where people still have a lot of say about what exactly happens, to a federated model where, I think the confederated model in my mind will have things like one ethics committee, one site clearance committee, one set of research grants. We're already talking about doctoral training programs being located in health facilities rather than at the university. So we're already seeing that end of it. What we're going to need from the health system and broadly is we want to see a real investment in the intellectual end of what's going on so we can improve health services. So I think all of them understand that is that's the outcome everyone's after. What we're having an arm wrestle about is what percentage of turnover that is. So I've said to everyone that, look, unless you put in 1% of your recurrent into research activity that's verifiable and auditable, you're not going to play, because in 10 years' time, you'll have to have 4%. And if you talk to the people at Imperial, it's actually 16%. They put in 8%, and Wellcome Trust puts in 8%. Like, it's incredible. And that started at 6%, like 12 years ago. So there's also quite a lot of talk at IPA level, the Hospital Pricing Authority level, about how you'd fund research, because it's chunky and not just related to patient turnover. And I think we'll see clusters, so blocks of money going, probably based on research staff FTE. So, because there's no other way of doing it. You can fund education based on how many bed days there are, and that's largely correlated. And there's been pretty good consultants out in the field doing that, led by Queensland really. The research side is not just related to patient turnover. There's small places that do research, and there's big places that don't. And so research staff FTE, I think, is going to be a major thing. Everyone ought to think about that. So there's some early examples. So we've JCU picked up 84 million to establish the Institute of Tropical Health and Medicine a few years ago. 42 million from the state, 42 million from the feds. 1.5 million of that we've targeted at Mackay, with some prescience actually, trying to locate depth of activity that that areas could be individually famous for. OHS to me has often been good at Mackay and important. There was a leptospirosis cases in the 1990s that no one wanted to talk about, either the unions or the employers or the health system. And but GPs would see the cases, but there wasn't much appetite to actually doing something about it. It was the rats in the cage storage areas. Now you've got, and so we had an argument about that in that part of the world, and then there was the black lung stuff, which sort of suggests there is an ongoing issue, and because you can't get black lung, I don't know, those who've ever seen it or learnt about it, even me going to medicine ages ago, I don't think I've ever seen black lung, heard about it, but it exists in Australia in the 21st century. So it's really important, but it can't happen with normal OHS activity, and it requires people turning their eyes away, both at employer, union and employee level, and quite possibly the health system not paying enough attention. So anyway, it's a big deal. It looks like that's now gaining traction. The state's talking about putting in money, the feds are talking about putting in money, and the unions are talking about putting in money. So there's an example of an activity that's come out of this that wouldn't have occurred otherwise. There's a database linkage going on about mining projects across northern Queensland is the word I'll use. There's quite a bit of activity around economic assessment of health services cost and efficacy. with the Academic Health Centre, and JCU and ARTHM have got a group of health economists now looking at health service provision and trying to work out how you decide on which pathway compared to another pathway, for instance. And that relates to enhanced primary care models integration. So the idea here is that we're already starting to do joint appointments, certainly with Townsville Health Service. There's now a Director of Clinical Services, jointly funded between JCU and the hospital. Clinical Research Services, yeah. So we pinched him from Royal Melbourne. The handy bit of that was his significant other is probably Australia's best TB person. So, and given what's happening inevitably in the Torres Strait, that's actually really important. So we're doing quite a lot there now too. That's one of the things I think would be judged by. Did you do anything useful around, you know, TB outbreaks, Aedes aegypti, albopictus, and the various other things. So in terms of the PHN's commissioning of research, there's a whole range of pretty obvious type activities. I think the issue now is, what's the detail of that? So you can say health economic statistical analysis capacity. What does that mean in a project title? And how would you know what the outcome is? So some of the things I would highlight though is that I think that there's a new role for general practice and particularly general practice, but probably pharmacy practice too, around relatively silent diseases like Zika. So Zika is a cousin of dengue, right? And it's a cousin of chikungunya. They're carried by Aedes aegypti that we've got plenty of. You've probably seen the media about Scott Ritchie and others at JCU shoving Wolbachia bacteria into the Aedes aegypti and I'm seeing some nodded heads, and then releasing them in suburbs of Cairns and then all of Townsville. It's quite clear that that made a dramatic difference to dengue transmission because for some reason Wolbachia, which exists in nature, once the Aedes aegypti is infected with it, it can't pass the virus on. No one's exactly sure why, but it certainly works at a macro level. So, and that's why Scott was sort of over in Puerto Rico and various other things, wondering if it might also work with Zika. So why I think that this sort of, as our firepower improves to detect and name conditions that can quite often be asymptomatic, but every now and again throw up serious cases, you don't, unlike dengue, you don't mostly know that there's a Zika outbreak on because nearly everyone is asymptomatic. Takes me right back to the early years of dengue in about 1992, 1993, when there was a big outbreak. Townsville had 3,000 cases. It's just we didn't know what it was. There was an outbreak of something and people launching into GPs all over the place. The tests at the time weren't fantastic and it was cross-reactive with rheumatic fever and a few other things. And people are going, like, doesn't look like rheumatic fever. Yeah. So it's got joint pain, and what else is it? The examination of large volumes of Red Cross blood was one way we could see the change in the virus pattern. And it only took some months before people pinned down dengue. What was interesting is if you looked at the North Queensland population around Charters Towers, which seems to have so much dengue, no one can believe it. It's because everyone waters their garden. They've got all these trees and it's always green, right? So 80% of the, this is Joe McBride stuff, I think 80% of the population had dengue markers in their blood of all types. And every type has walked through North Queensland at some point since the Second World War. And of course, it's the second infection. For those who don't know, it's not so much the first infection that gives you hemorrhagic fever, which is very dangerous in children. It's the second infection. And we did see in adults, no one with life-threatening disease, but people bleeding a lot with what turned out to be a second infection. So that was sort of interesting. So I think the role of, I've finished. So the role of things like academic health centres in the development of work plans, the development of an evidence base, the creation of bridges to both the hospital system and the university system, bringing primary care into the things we really expect or have traditionally expected in a teaching hospital. The reality is that, just putting it on the table, apologies for those who are offended, the reality of our hospital system is it's come a long way in 25 years. The Bundaberg experience of 2004-2005 could have been emulated in some of our facilities. At least in North Queensland, all the facilities have done something about it. Actually, in some parts of Queensland, it's just the same as it was. So North Queensland's done a good job. A lot of our big health facilities are really big country hospitals that have dragged themselves into the 21st century and understand that they have to provide services at a much higher level, and they have to participate and have the potential to participate in the national debates around areas unique to us all in a way that is difficult anywhere else. And I think Melbourne no longer argues that you ought to do all this stuff at Royal Melbourne and Alfred Hospital. So that's actually quite interesting. So there's a Northern Australian agenda which offers incredible scope. And the creation of a PHN, even though it's in early life, it definitely, from the people involved that I run into, it definitely has an appetite to play seriously in this space. My guess, you can be globally famous by doing it. If you look at the Medicare local experience just before this PHN period, to be honest, there were about 4 of them that were doing anything good that you could measure. And that was a lot of, for spending more than $500 million a year, that was a fair bit. I'm going to get electrocuted because I've been talking too long, but I am finishing. But the opportunity for the PHN to be actively involved in the shaping of what the research agenda is, and therefore what your outcome agenda is going to look like, is a great opportunity. And I really think you've got terrific people, but you've got to let them have their head, and they'll also tell you things you don't want to hear. And that's what's beautiful about it. Thanks very much.